Yeah, good evening, everybody, and good morning to people from the West Coast and the East Coast in USA. So it's really nice to be a part of this webinar, which is the biomechanics webinar. And it's a privilege and a proud moment for us to have none other than Dr. Anil Bhave for this webinar. He will formally be introduced by Dr. Sona, but all I can tell you is that I have known him now for more than 6 years, but I have actually known of him for more than 2 decades now. I used to read his papers when he used to write with Dr. Herzenberg and Dror Paley. And, his name used to figure in all those papers. And that's so many years back I have known about him. His work in locomotion and biomechanics and musculoskeletal is phenomenal. And for the last 3 years, I have known him very closely because he keeps coming to India and he keeps coming to Sancheti Hospital to train our physiotherapists and hold various scientific and academic programs. He has influenced the way we give physiotherapy at Sancheti Hospital to our patients in a big way. He has taught us the new techniques, and it is really a proud moment for me to welcome Dr. Anil Bhave for this special webinar organized by OrthoTV, Indian Society of Physiotherapists, along with Sancheti Institute. So thanks, Dr. Anil, for joining us, and welcome to this webinar. And I hand over to Dr. Sona to further formally introduce Dr. Anil Bhave. And then we will
Thank you, Parag.
We'll all be eager to hear the master. Thank you.
Thank you.
A very good evening to everyone from India and a good morning to everyone joining us from the West Coast. I guess Dr. Anil Bhave has become a regular with OrthoTV also. He is a well-known figure in the Society of Indian Physiotherapists. So I guess he needs no introduction, but just to give a few words of introduction for people who are hearing him for the first time. He's had more than 100 papers, close to 100 papers in peer-reviewed journals. And he is the clinical director of the rehab services at Rubens Institute of Advanced Orthopaedics and Sinai Hospital in Baltimore. He's also the director of the Gait Lab there in Rubens Institute of Advanced Orthopaedics. He's had a vast experience in rehab services, and the best part about him is he has never stopped growing as a therapist. So even though every time we meet him, he has something new to share. And that's the best part about him. The knowledge, when we meet him or interact with him, just keeps growing and growing. And there are so many pearls of wisdom that we have to learn from him and apply it to our daily practice. And the best part about his advice is his clinical nuggets, all right? Or I think, as I just mentioned, the pearls of wisdom really work with the patient. So he gives a very sound and clinical advice, which comes from his vast experience of treating so many patients and dealing with their issues. So yeah, without wasting much time, sir, I hand you over the proceedings.
Thank you, Parag, and thank you, Sona, for a great introduction. I am going to tape this and send it to my mother. She'll be very happy to hear what people in India talk about me. So I'm going to start sharing my screen, and we'll go through these slides very quickly, and then we'll take questions and answers as we go through this. And everybody see my screen, right? Okay. All right. Today we're going to talk about human locomotion, especially the clinical implications. Usually this is a 3-day seminar or lecture. We're going to try and compress it into an hour of most clinically valuable pearls or tools that we can use in analyzing gait. Not everybody needs a gait lab. You can do it a lot with your smartphone. That would be one of the themes of this lecture. So let's go through what the belief system is. So my influence on gait analysis was largely by a lady doctor named Dr. Jacqueline Perry from Ranchos Los Amigos in California. Those who don't know her, she was a physical therapist in early 1930s and 40s before the World War II. Many of you don't know what World War II was, but I know. And during that time, she treated a lot of army injuries that happened. She also treated polio. Then she used the money that she got from working as a therapist in World War II, then became an orthopedic surgeon and had a special interest in treating locomotor disorders. She set up the first gait lab in California. And a lot of the concepts come from her book, Gait Analysis by her. And I have a special memory because I met her many times and I have her signature that says, "Best regards, Jacqueline Perry." So I cherish that book. I cherish that knowledge that I took away from her. There are other people who influenced my thinking, but she was the primary one who changed my focus to way look at human locomotion. And one of the most important concepts she discussed was this concept called what is a locomotor unit and what's a passenger unit. In our body, when we walk, we have a system of pelvis, hip, knee, ankle, foot. That is a locomotor apparatus that moves us. But then we are carrying the load of the pelvis, lumbar spine, the thoracic spine, and all of the body. That's a passenger unit. And the passenger unit has to be moved. And as the passenger unit moves or changes its direction, then there is an interaction between the ground and the body. It's called ground reaction force vectors, and it affects the way we interact with that. The passenger unit is about 68 to 70% of the mass, and the locomotor unit is only 30% or someplace 28% of the mass of the total body. So as a passenger unit has a very large influence on how we move, and that's a concept that was made clear by Dr. Perry. What is gait cycle? How we walk? We walk from heel strike to heel strike is one gait cycle, or one event to same event, because sometimes you don't have a heel strike, you may have a toe strike. So toe strike to strike is one gait cycle. So gait cycle consists of stance phase and swing phase, which is where stance phase is more time, swing phase is less time, about 62 to 38% of the time is spent in the swing phase and stance phase. You have initial double support time, a single support time, and a late double support time. This is different for walking than running, because in running you don't have a double support, but you have a double float. Both the feet are off the ground. So that's the difference between walking and running. And in walking, you have initial double support, single support, and late double support time. And in the swing phase, you have again initial swing, mid swing, and terminal swing. If you look at the timing or how much time in the gait cycle is, the step time approximately 0.6 seconds is what we spend. The total cycle time, depending on the speed, is anywhere between 1 and 1.2 seconds. That's the total cycle time. Now, why do I emphasize on this? Is that means our muscles have to flex and extend in that short period of time. And your patella has to ride at least 4 centimeters on the trochlea in that quick time of 1 second. So if you have any stiffness or spasticity, a gait will immediately show it, because you have to contract, relax, contract again, as well as relax again. as you go through this very short period of time. So that's a critical message that we have to transfer, is that what you see on clinical exam is not always what you see in gait, because it has to happen very quickly within a second of time. And then there are other parameters. We have talked about this a little bit. Your heel to heel base of support is approximately 8 to 7 centimeters. A single support time is about 36 to 38. And the double support time is 25%. And then the swing phase is about 38%. And stance phase is about 61 to 63%, again, depending on speed and walking. So those are some of the things that are important to know and remember as we analyze patients' gait. What is a gait cycle? So look at this gait cycle here on the right leg. This is a heel strike of the right leg. And then you have the loading response as the other leg is coming off. And then you have the right side is pushing off, and the left leg is dropping down as heel strike. So you basically have duplication of the activity of the right leg on the left leg at a different time sequence. And that's how the gait cycles are defined. And any asymmetry, any change in the way we see the gait, we call it a limp. Limp is nothing but either the timing is not right, or the angles are not right, or both are not right. And that's what we see in the legs. In the trunk, we see other things. We'll talk about that in a second, briefly. This is probably the most important slide, because all pathologies in gait can be crystallized down to one slide. So these are prerequisites for normal human gait. You must have stability in stance, or we call it equilibrium. When we are in single stance, you're balancing your entire body on one leg. So you must have stability in stance, in the trunk, in the pelvis, to the hip joint, knee joint, and ankle joint, and foot. You must have enough clearance in swing. Clearance in swing very important, because if you have a foot drop gait, then you have to hyperflex your hip or knee, or you have to do other compensation like a circumduction or other things to have clearance in swing. Well, what is the distance that the toe, the great toe, is away from the ground when you are actually walking? The minimal distance clearance is 1 centimeter only. So you have a very small room for a fault or a failure of the ankle, hip, knee complex, because all you get is 1 centimeter of clearance when normal walking is there. Correct positioning and terminal swing would apply more to like ataxic gait, or somebody who doesn't have good control and cannot step over step, and that would be correct positioning. You must always step one step over the other, and we try to keep a distance of approximately 7 to 8 centimeters, depending on the height of the patient that changes, and then we must have adequate step length. The classic example of that is hamstring gait. When the hamstrings are tight, you don't have adequate step length. So that would be one easy example. And the last one that is very critical is energy conservation. We must conserve energy because we want to walk unlimited distances. We do require some muscle strength to work in gait, and we must recycle our motor units better to actually have that type of strength to continue. And energy conservation is achieved by three things mostly. One is there is some degree of pelvic motion, the pelvic drop, as well as there is some motion in lumbar spine that allows for center of gravity to be maintained within 2 to 4 centimeters of up or down movement and side to side movement. Controlling the center of gravity movement is very critical in order to conserve energy, because when the center of gravity is away from the locomotor unit, you have to spend more energy to control it. That's number one. Number two, most important thing is we use our muscle very discreetly and for short bursts, and they are not firing all the time. While as in when you lose neuromotor control, they are firing all the time, so patients can get very fatigued very quickly. The other thing that we do is most of the work that is done by muscles is in eccentric control and not so much concentric. One of the classic examples of that, the concentric control only comes in for the gastrocnemius soleus complex for push-off, but a lot of this transfer of energy happens better with eccentric muscle control. And as you know, that eccentric strength is far greater than the concentric strength, so you have more resistance to fatigue. So you conserve your energy better when you're using eccentrically. So those are the 5 things, and you can probably fit every problem you see in the clinic with these 5 prerequisites to make the gait normal. So it's as really, this is the most simplified slide I can show you to understand that. This is how we stand. We stand in double stance, but we walk with a slight inward or a adduction of the hip by about 4 degrees. And that's how we have a step width of 8 to 10 centimeters, while our pelvic width can be up to 20 to 25 centimeters. And then I'll show you an example of how people actually maximize that to put a disadvantage. This is an important concept about ground reaction force vector. So what is ground reaction force vector? Is that this is your passenger unit. The passenger unit is 70%, and the center of gravity of that is around T10. And when we walk, there is equal and opposite force. It's called ground reaction force vector. So there is a ground reaction force vector that's acting in this direction. Then you have hip joint, knee joint, and ankle joint in single stance. So now the hip joint, if this leg is off the ground, the hip joint has to act aggressively here to control so that the whole body and the pelvis doesn't drop this way, which is the function of the abductor mechanism, including the fascia lata iliotibial back. Here, it's vastus lateralis, lateral ligament complex, IT band, that controls the balance because the vector is more medial, so the body wants to collapse like this, but these structures outside have to control it. And then in the ankle joint, it's mostly related to the tibiofibular joint and the tibialis posterior action that controls the way the body wants to work against the ankle joint. So there's always this balancing reaction or equilibrium that has to be obtained throughout the stance phase to do this better. What is body's natural reaction? This is an example of a hip joint. So if you're walking like this and you have dysfunctional abductor mechanism, you're trying to bring your center of gravity of the upper body over to the side. So you reduce your lever arm, so you reduce the demand on the hip abductor muscle. You can only do so much because otherwise you will be in imbalance. So that is what we call a compensated Trendelenburg gait, meaning that the body's ability to compensate for a pelvic drop that would have happened because there is no stability here. It could be from gluteus medius or minimus weakness, it could be from weak tensor fascia, or it could be all of that, or it could be just detension fascia lata, which is a tension band here. So all of that is then as controlled by moving the trunk over so that you reduce, and that we call that a compensated Trendelenburg gait. Because what is Trendelenburg sign is actually a pelvic drop. So the pelvis drops as you walk, and this is the more detailed image of that in terms of what it looks like when you are walking normally and you have good abductor mechanism, and it needs to be 2 times the body weight, because 2 times the body weight of the passenger in it, because this distance is twice that of this distance of the muscle. So, but when you lean over this way, you reduce the amount of work that needs to be done, and thus you can protect your abductor mechanism a little bit better. Well, what happens when models walk like this? What is really happening here is that by bringing your step width to 0 or negative step width, you are detensioning your abductor mechanism to a point that the only way you can walk is you drop your pelvis. So they intentionally walk on a runway like this so that they can drop pelvis because they are detensioning their abductor mechanism so much that they can't control the pelvis and it drops. And we call that sexy, because the pelvis drops from here, and the next stance when she's on the right leg, this pelvis drops here, and it looks good on TV. And we go to see that for Victoria's Secret shows. But the mechanism is very simple. This is a deliberate, uncompensated Trendelenburg gait. That's all it is. And that's how they achieve it. So the next concept is, this is a very important concept. I think this is something that a lot of hip surgeons know about, want to, they get into trouble with this many times, and I'll show you why. Because a fixed adduction deformity or a contracture where patients cannot abduct and they are in adduction is compensated in gait by tilting the pelvis over. Well, what happens with that is when you do that, you actually shorten your leg. Your leg gets shortened because you're tilting the pelvis over to compensate for this adduction because your foot is off here. But when you stand, you got to stand like this. Now that causes apparent shortening. So this is an example. Next example is actually an example of adductor contracture causing, if you see the pelvis is tilted. So it's going to cause an adduction contracture and an abduction contracture on the opposite side. And that can lead to significant dissatisfaction in patients. It has nothing to do with hip replacement. It has everything to do with normalizing the range of motion of the hip. And that's been something that I have observed many times in hip replacement patients. They have abnormal muscle tone initially after surgery that becomes a fixed contracture later on. And then we need to carefully assess it and see if this difference in standing is because of that. Why do I say that? Is if you draw a line from the pubic symphysis, or not pubic symphysis, from the ischial tuberosities all the way down, the lines falls on the lesser trochanter on both angles same. So there is no difference between the height of the center of the head of the femur to this line on either side. So it is because of this pelvic obliquity that is caused by the adduction contracture. And the opposite of that is true also, where there is an abduction or tightness of the tensor fascia or IT band. All those can cause some degree of abduction contracture, but you don't stand like this, you stand like this in walking, and thus you cause an apparent lengthening. And many people after hip replacement surgery or hip surgery per se may feel that they are longer on their side. And please don't give a shoe lift to them, because if you give the shoe lift, you never stretch the muscles out. And what I recommend is proper therapy to address that abduction contracture. And that's an example, again, of this line that goes through and shows equally on both sides, but pelvis is tilted down, and that's because of the fixed abduction contracture on this side. This is a very common problem I see in hip surgeries and needs to be addressed to normalize the gait. You need to reduce that hip abduction contracture, or at least ability to adduct the hip easily to 5 degrees to 10 degrees, and then this usually goes away. So that's a take-home message for that. Now, looking at the sagittal plane, the ground reaction force vector as shown here interacts with the hip, knee, ankle differently in different phases of gait cycle. That's your heel strike initially, and then you're going into a toe-off phase. And the demand for the muscles to activate is different because the ground reaction force vector changes the direction throughout the gait cycle. So for example, initial stance, the ground reaction force is slightly posterior, and all you're doing is really working on your tibialis anterior to lower the foot down slightly. We call that a eccentric contraction of the tibialis anterior to lower the foot down, or first rocker of gait cycle. And then as the ground reaction force vector more anteriorly, posterior capsule is tight, the hip extensors have to work. The next is loading response. This is very critical, where you see the quadricep acting very well to control the knee because the ground reaction vector is posterior. The knee flexion is essential for shock absorption, but also can cause a problem if you have quadricep weakness. And this is in normal walking, this is what you need. And then you have the action of the triceps surae of propulsive phase of the gait cycle, where you're going from a mid stance to a terminal stance, and that's when you use your muscles. So that's how the terminal stance occurs, where then the ground reaction force vector is slightly in the anterior of the ankle joint, and you're pushing off of that cycle. In swing phase, the most critical muscle is really because the momentum of the leg takes it through. But in order to get full flexibility at the knee of 67 degrees of knee flexion, you must have good flexibility of the rectus femoris. That means your hip is extended fully, or maybe 5 degrees, and your knee can flex at least 55 to 65 degrees. Then you get the normal knee flexion angle here. So you should always test patients when you suspect a stiff knee gait with a rectus femoris test. We call that Eli test. And if you suspect spasticity, you do a R1 and R2 test for spasticity patients. This is a slide that I actually got from a gait lab in Melbourne, Australia. And I want to spend a little time with this on this slide. So what they did was they looked at, they did a manual muscle testing as well as analysis of the walking moments that are expressed in Newton meters. And what they found is, if you're doing a grade 3 contraction, what is the contribution of the muscle? How many percent of MVC is it? And if you look at that, dorsiflexors are about 4% of the total MVC when you're doing a grade 3. But you need 22% of that in every gait cycle. For plantar flexors, you need 90% of your MVC for every gait cycle. And knee extensor, you need about 40%. So, more than 1/3 strength. So if you look at this, I've made it simplified for you. So normal gait, extensors, you need at least 30% of the grade 3 or a little bit more. Hip flexors 3 or a little bit more. Abductors 3+. Knee extensors almost 4 to 4+. Knee flexors only 3. Ankle plantar flexors almost 90%. So we need to test our ankle always in functional testing and not in manual muscle testing. It doesn't give you the correct result. And the dorsiflexion at 1/4 of the body weight. So this is the contribution of muscles. So basically lower extremity, some muscles work at 4 to 4+, and some muscles work at 3 to 3+. And we need that for every gait cycle. So we must have adequate motor units that we can recycle, otherwise we can't walk normally for long distances. So that's the important slide to show you. The next important concept is this range of motion of the hip, knee, and ankle. The dashed line here is hip joint. The dashed line here is the knee joint. This is knee joint. The red line is a hip joint, and then the white line is the ankle joint. And if you see, the critical thing is in the mid-stance phase, all joints become almost zero. So in mid-stance, the hip is fully extended. The knee is about almost fully extended, but it comes from 0 degrees of extension, a heel strike, to 20 degrees of flexion, back to 0 degrees, and then slightly hyperextension, go back to about 68 to 70 degrees of knee flexion in swing phase. The hip goes with it, kind of, and also flexes to about 40 degrees in the swing phase. The ankle actually first plantar flexes slightly, and then dorsiflexes to about 10 to 12 degrees, then plantar flexes again, and then kind of stays in the terminal stance at neutral to slightly plantar flex position. The critical component of this, and this is something that I always observe, is that we observe patients from the front in our clinic. Walk to me. That's what we tell them. Walk towards me. But we never have them enough runway to walk on the side. You can pick up a lot of things from the side, and this is observational gait analysis. Does not require, again, any sophisticated methodology. But you want to observe at mid-stance where the joints are. They need to be at 0. And if they're not, you're going to see it. And that's what I mean by using the smartphone or using the slow motion video on your smartphone to assess at this point in mid-stance phase, and also look at the total action of ankle, hip, knee, and ankle. So this is a very critical slide to remember in terms of what the motions are, and everybody should know by heart that you need 10 degrees of dorsiflexion, about 20 degrees of plantar flexion, you need 40 degrees of hip flexion and almost full extension, and you need 0 to 70 degrees of knee flexion during walking. And then everything changes with faster walking or running. We call these rockers of gait. This is the first rocker where there's a heel pressure, and there's then the midfoot rocker where there's pressure that is transferred to the entire foot. And then the forefoot rocker is really forefoot rocker where you're rocking on the forefoot, and that's how it happens. And this is just a pictorial view of what the ankle range of motion is not that much. It's small amounts. It's 10 degrees of dorsi, 12 degrees maybe, and 20 degrees, 15 degrees of plantar flexion. It's not a lot of motion, but every degree in ankle matters during gait. Even 5 degrees matters in gait cycle. And the other thing that we have to remember is foot progression is always external, 6 to 8 degrees from the knee joint axis, foot is out, and that's what is normal in walking. So let's take an example of equinus deformity or contracture. Deformity is bony, contracture is soft tissue. So let's see if the patient is like this. Well, what happens? The first thing, this is only 5 degrees of equinus. The first thing that happens is the single support time changes, 29% to 37%. and the step lengths reduce on the opposite normal side to 37 centimeters versus 50 centimeters. So there is an introduction of asymmetry that happens in step length, single support time, just with 5 degrees of equinus posturing. And an improvement of 5 degrees into 5 degrees of dorsiflexion results to almost normalcy in terms of single support time of 37% on both sides, and improvement in step length from 37 to 59 centimeters quickly. So 5 degrees of dorsiflexion can lead to closer to normal gait, not perfect, but closer to normal gait. So it's very important. But the other thing that is important, which I'll show later on, is how quickly we need to change from a plantar flex to dorsiflex position, less than 0.1 seconds. So the tissues have to be flexible to actually get that done. So this is a typical gastrocnemius orthopedic problem, and I hope the videos show well, but I will slow it down. So you see this guy has a slight knee flexion contracture, so no hyperextension compensation, and you can see that's how he walks. So basically orthopedic problem, he has reduced dorsiflexion in gait cycle, and that's what you see. Well, what happens when you have a spasticity? So if you see, she comes in, this is knee, and what happens in knee-ankle interaction is she comes with flexion of the knee and rapidly hyperextends because her ankle starts going from a dorsiflexion to a plantar flexion position. So compensate that, the knee has to go backwards. So we call that knee extension plantar flexion coupling, and that happens with spasticity. It can happen with tightness, but most commonly with children with spasticity. And then again, as the knee flexes, the ankle can dorsiflex a little bit, and then there's a reduced knee flexion because she's spastic. So that's what a typical pattern of what we call ankle plantar flexion knee extension coupling happens with any abnormal tone in the muscle. This is a natural progression of a clubfoot patient. So a clubfoot patient has restricted ankle, and then when they walk, they compensate through hyperextension if they have it, and they stretch out their posterior capsule and PCL, and eventually have a hyperextension gait. So it's important to manage this when they are younger, so they don't have secondary deformities of their knee joint, and that's critical. This is one of my very educative cases. This is a patient that came to us with severe spasticity, with having a lot of knee pain. She had come to our joint clinic because she wanted a arthroscopic surgery done. Somebody had done it already, and she had no resolution of her knee pain. If you observe her very carefully in slow motion, what you will see is as she walks, she doesn't have much dorsiflexion, and she is just kind of levering forwards, and her trunk is coming forward, and you can see right there, and trying to hyperextend the knee so that her opposite foot can extend over the supporting leg. So that produces a significant compression of anterior knee. So instead of treating her knee joint, this is what we did. So we basically addressed her ankle complex through a botulinum toxin injection with serial casting and then AFO at night. And we managed her for many, many years like this. She has no knee pain, and she's walking. And if you see her carefully walking, you can see that she is able to transfer her weight and have actually some dorsiflexion. Carefully see that again here. This one is very clear right now. And as I go through, as her opposite leg is coming over, she actually has dorsiflexion. You can see that up to about 7 to 8 degrees of dorsiflexion you can have as she comes through. And that allows her to have better step lengths and no knee pain. So always when you have problems that you suspect, always check the ankle joint. It's very critical. This is an example of a fused ankle that has MRI findings of the same thing, of the articular cartilage degradation because of walking in equinus. That's another example. Well, what is the other price for walking like this? This is a fast idiopathic toe walker. And people who treat cerebral palsy have seen this, but you see this in idiopathic toe walker also. If you see this idiopathic toe walker, they have tightness of the gastrocsoleus complex. And one of the deformities that we commonly see with them is this early hallux valgus deformities. And sometimes they even have a midfoot breakdown because they are flexible joints and ligaments are flexible. So they can have, so controlling that early age doesn't lead to the type of bony changes that occur here. And the best example of that is long-term follow-up on a technique called Ponseti technique for clubfoot. And if you look at all the literature on Ponseti technique, when you address this early on, very early, like newborn, and do the correct tenotomies and do casting, then these bony changes don't occur in patients. And that has been a big part of the management of the clubfoot all across the world, including India. And then there is, of course, some degree of shoe wear therapy, all that is associated early on, but then you don't need a lot of care later on in their life. So that's the concept that came from some targets. And this is my hypothesis, is that sexy shoes called painful feet, because what you have is a high, a narrow toe box, a higher heel, and that produces the same type of valgus movement on your forefoot, and eventually leads to these type of very painful feet. And there is this cost of wearing high-heeled shoes. And there's actually a paper in Journal of Orthopaedics and Sports Physical Therapy that has shown that anything about 2 to 2.5 centimeters is not good for women's feet. So heel, the heel of up to 1 inch is what they recommended in that paper. And anything above that on a regular basis probably causes problems in their feet. The other thing that I learned from Dr. Perry, Dr. Jacqueline Perry, was never use too much force when you examine the joints. Because if you have to use the force while you try to stretch the joints, you're never really going to assess them for functional range of motion. So if you apply a lot of force and you get passive range of motion, it won't be useful in the gait cycle, because the transitions from a plantar flexion to dorsiflexion to plantar flexion or knee flexion to extension are occurring within 0.1 to 0.2 seconds. Actually, 100 milliseconds is all you need for the transitions. So that transition to occur, you must have the correct flexibility for it to be working. And this is the essence of physical therapy, in my opinion. And this is not about gait analysis. This is about essence of physical therapy, is that what is the functional motion versus what is the examined motion. So I always do this where I'll do passive just to see where it can go. I do passive with ankle flexed and ankle extended to check for gastrocnemius. And then I also do active dorsiflexion to see what patients can do with knee flexion and knee extension. What does that tell me? It tells me how much activity patient can do. And the other thing that she recommended was always use 3 fingers of your examining hand, index, middle, and thumb, just to move the joint slowly, and then a little bit faster to see how flexible the joints are, because that's the amount of flexibility you need for normal gait. And that's something that is lost in the teaching of today's world. We are very regimented in terms of measuring active, passive range of motion, but this clinical skill needs to be taught and developed for all our students, including both orthopedic surgeons, medical doctors, and therapists, to have a complete understanding of what functional range of motion is. And this is the best example of that. This is a patient who has an ankle fracture. If you have the X-ray in standing with maximum dorsiflexion, one can argue that he has easily 10 degrees or more dorsiflexion. But if you really see him walk on his right side, you can see that he's only walking on his toes. He's really not functionally loading his heel. So he doesn't have the capacity to actually use his flexibility, and that needs work. That needs, and it's another lecture, but it needs soft tissue management. It needs splinting. It needs other things that need to be done to improve the patient's outcome. So she always talked about apply minimal force to assess functional range of motion, and that's that message has resonated with me all my life. I always have done it like that, and I've found it very useful to function like that. And when you don't do that, this is what can happen. This is a spastic patient with a complete broken down foot. We call it a rocker bottom foot, because when he walks, his
So you're muted.
I got it. I lost my audio. Okay. So I'm sorry about that. I will go one more slide back. So this is the important thing about MTP joint. You need 55 degrees of dorsiflexion with ankle in neutral or slight plantar flexion to achieve that. So it's important. You can see here ankle is in neutral versus this ankle is in equinus. This is equinus and this is abnormal in terms of MTP joint. So next slide is what is closed chain problems. This is a classic example of a foot that is in equinus leads to rotation of the pelvis and trunk because the ability to advance your other foot is reduced because of this dorsiflexion on the right side, affected side is reduced, and thus you have to rotate your pelvis, and there's a rotation, counter rotation that happens in the pelvis and trunk, and people call that a closed chain abnormality. And there are many like that in the Gait Cycle. I'm just giving an example of that. This is a nightmare, in my opinion. I can take equinus any day and work with it, but I have a trouble treating this every time, especially as children get older. Very difficult to manage these problems. Some of these are iatrogenic, some of these are caused by just the disease. But when you have hyperdorsiflexion like this, you have no propulsion, you only have absorption. So when the tibia when the ankle is dorsiflexed, hyperdorsiflexed, the tibia just keeps going forward and the patient is basically falling. And the only way they can control that is through their crutches. And this is a more graphical representation of that in terms of ankle problems. And you can see hyperdorsiflexion and prolongation of dorsiflexion. And we call this a calcaneus gait. And the usual treatment for that in children, at least, is ground reaction, AFOs. And there are some unique surgical options that were initially presented by Dr. Gage and Dr. Kurgram from Melbourne, Australia. And that's a separate topic. We can discuss that. But what is more important for regular common therapy is that you must assess the plantar flexor muscle very effectively. And manual muscle test is not enough. So Dr. Perry taught us a test called single stance heel rise test. And without support, you can just give balance in the hand. And she said you must do about 30 of these to call it a normal plantar flexor muscle or plantar flexor complex, because it's just not just gastrocsoleus. There's also FHL involved when you do this activity, and tibialis posterior. So she recommended you test this by having this done 30 times. And if they can do 30 times, you probably have good enough plantar flexor to walk. So that's something to take home from here, is that that's the kind of muscle strength you need to walk normally. This is a very important concept, and this is for the people who do manual therapy. It's very critical, but it's critical for all therapists to understand this. I don't know if you remember Blix Curve, B-L-I-C-K-S. Blix Curve is basically when your muscle shortens, it loses power, loses strength. So here is an example of an ankle plantar flexor working against a lever arm that is from the center of the ankle joint there, center of subtile joint here. And you can see that this is the moment, the muscle force. As you plantar flex, the muscle gets shorter. But then there is also an anterior glide of the talus that maintains the lever arm or increases the lever arm. So by increasing the lever arm, you actually get more enhanced muscle function. So you don't lose as much strength. This is a very critical component of ankle in terms of getting more strength as you go into plantar flexion. So a proper glide to achieve plantar flexion, dorsiflexion range of motion is critical to get the adequate muscle strength in walking. So that's just an example of that. Plantar flexor muscle is a very useful muscle, and people who do total knees bilaterally, they have heard about this. This is a guy who went to a restaurant, and his waiter, he thought the waiter had placed the chair. He was about 6 weeks out from bilateral total knee replacement, and he thought the chair was there, but he sat down, the chair wasn't there, so he went down and he tore both his quads. So if you see, this is how he walks. He's using his plantar flexors muscle only to walk because he has no quad muscle. And if you analyze his gait very carefully, what you see, and I'll slow it down so you see it better, is this is what happens when you use your plantar flexors correctly and position your body in such a way. If you lost my audio before, this is a bilateral total knee patient here who lost both his quads because he tried to sit down on the chair when chair wasn't there, so he tore both his quads. The quads were not repairable, and that's how he walks. And when he walks like this here, you can see that he's positioning his ground reaction force vector much anterior, and that's how so the plantar flexor muscles can be very, very useful. And I tell you the best example of that, I learned it when I was in India, is positioning the ankle in 5 degrees of equinus in absence of quad strength was the only saving grace for a lot of polio patients. The only way they could walk better was having that slight extension or hyperextension at the knee and controlling the knee so that they don't get a loading response deflection. They keep their knee fully straight and they use their plantar flexor knee extension moment to their advantage and walk better. So that's one of the compensations that one can do. I'm not going to spend time on this. This is the action of tibialis posterior, and that's what controls it because the body vector line is slightly lateral to the ankle joint. So there is compressive force on the tibia, on the fibula, as well as there is a peroneus control. I want to show you one slide. This is a typical compensation for a varus knee. A lot of people believe in orthotics, so I'll just mention that here. Not all orthotics work on all patients, and they'll tell you why. Because there is such a great variability in the subtalar axis. We have a high and low subtalar axis, and this is a variation of the subtalar axis. So if you have a very high subtalar axis, you're stiffer. You have a low subtalar axis. So because of that, not everybody works well with orthotics. So we have to judge it based on their subtalar mobility because of the compensation that is available there. And that's the best example of this patient having bilateral varus leftwards than the right, and see what happens to her tibialis posterior and the tibialis posterior nerve when she stands. There's a lot of pressure that can occur from that. This is a test for tibialis posterior patency or functioning of the tibialis posterior, and I always do this test. She has planovalgus feet on both sides, but if you look carefully, she can actually supinate her heel, not on this side. So this is the side I want to treat for tibialis posterior dysfunction, not this side. So that's what I test all the time. Subtalar valgus is a compensation for gastrocsoleus contracture. This is the best example of that. If you put the subtalar joint in neutral, then you get a plantar flexion contracture, while as if you allow the subtalar joint to sublux into valgus, you can get a lot of dorsiflexion as shown here. So that's the important take-home message. Subtalar joint neutral, you have equinus. Subtalar joint in valgus with the foot, then you get dorsiflexion. So you have to control the subtalar joint through neutral subtalar to assess ankle range of motion for gait. This is a typical compensation The deflection contracture is from the hamstring, posterior capsule, gastrocnemius contractures. Or can be also bony, and this is an example of a bony contracture. We need to distinguish that between bone versus soft tissue, so we know what the best treatment is. Their presentation is also a little bit different with soft tissues. You have tightness occurring early. This is like a hard bony stop. And in the gait cycle, you appreciate it, and patients will actually tell you this is a normal extension at the heel strike. This is a flex knee at the gait cycle. And this is a common lack of knee extension, gait compensation that occurs with this. And then let me go back forward a little bit. I'll come back. Sorry about that. One of the things that I learned was that don't test your hamstrings only at popliteal angle or 90 degrees of hip flexion. Many of us have a popliteal angle positive at 90 degrees of hip flexion, but we all I know. I'm sorry. I don't know what is happening to my audio. So we are back to hamstrings, and hamstrings at 90 degrees of hip flexion. Can everybody else mute on the Zoom, please? Because I think that's taking over my mic. But hamstrings, don't check them at 90 degrees for gait deviations. At 90 degrees, we never use 90 degrees of hip flexion in gait cycle. Check it at 40 degrees and see if the hamstrings are flexible at 40, 45 degrees. Because that's when we are using, that was the amount of gait cycle use we do in the gait cycle. So that's the important take-home message, is that when you are trying to correlate hamstring tightness to the gait deviation, then you do this. If you are testing a sprinter, a runner, an athlete, or a hurdler, then you want to check the hamstrings at 90, absolutely. And you want full flexibility of the hamstrings, because that is critical for their function, but not for normal gait. Ooh. The other concept that we learn in the gait lab is when we did the musculoskeletal modeling, what we observed is that it is dependent on gastrocnemius length too. And about 4% of the gastrocnemius resting length is working on knee flexion, meaning it flexes the knee because the way it winds on the condyles. So when I test for knee flexion or lack of knee extension during walking and or clinical exam, I always test hamstrings at 45, gastrocnemius with knee fully extended and straight to measure how much of the gastrocnemius tightness is. Because remember this, if you are walking and you have tightness of the calf muscle and you want to achieve dorsiflexion, the only way you can get it is flexing the knee. So it's important to remember that and always examine like that for the assessment. And this is an example of that. Media not found. Okay, I'll show you another example of that. The other concept in the knee, and this is a concept for surgeons more than therapists, but this is a patient with weakness. What is happening here? Weakness of the quadricep muscle with a posture like this. He's leaning his passenger unit forward so that his knee joint doesn't buckle because it wants to be in the front of the joint. A supracondylar extension osteotomy with hamstring lengthening gets him that posture. And this is a gait concept that surgeons use all the time to get patients out of this abnormal trunk posture in gait. So it's not, and that's how I measure. I measure extension lag like this, but I also measure if they can achieve extension in gait like this. And that's the important concept, because you need to have full extension in gait, not just clinical exam like this. So that's how I measure. I want to spend about 2 minutes talking about this because this is probably one of the most important slides to remember as to how to manage arthritis of the knee. What I have here is Sona. Can you do me a favor and all the people on Zoom turn down their mic because it's the mic. My mic is being taken over by somebody.
Sir, our mics are off. I guess, yeah, from the Zoom participants, all of us are muted.
Okay. Yeah. All right. Okay. All right. I don't know why it's happening because I never have this. Anyway, so if you look at here, you can see that that's how you walk. That's how we walk. So on the stance phase, the green line with the ground reaction force vector is significantly medial to the hip joint and to the knee joint. And how are we going to balance that? We are only going to balance that with contraction of the muscles around the lateral side of the hip and the fascia lata, which is the elastic band, and the muscles that contract here for the knee joint. So if you have medial compartment osteoarthritis, then people say you should strengthen your quadricep muscle. That's very common that we tell everybody. But the gait analysis teaches me that I need to do not just that, but I need to address all the muscles that attach into the tensor fascia, iliotibial band, and fascia lata. So I need to strengthen hip more than the knee. So I need to strengthen the hip abductor muscles. I need to strengthen the extensor of the hip because they have an insertion into the fascia lata. I need to strengthen the vastus lateralis and the lateral biceps. Because all those muscles, when they tighten up and tension, they actually hold the IT band, which is like a tension band that controls the compressive forces on the hip and knee joint. So my belief is that if you strengthen all the muscles in the chain that are actually, and they are adequately firing, so there is some gait training required for this, you can treat a lot of the early osteoarthritic patients with proper exercise prescription, maybe orthotics. So my theory is based on this video here. And what we do usually is we strengthen the tensor fascia, abductors, extensors, vastus lateralis, and that's how we treat the patients most effectively. I'm not going to show these slides for sake of time, but this is also another important concept that osteoarthritis of the knee is not just a varus valgus disease, but also a flexion extension disease. You must get full extension because it's a combined varus and flexion moment that causes problems with arthritis. And that's been shown very well in the papers that I will share with you in a second. So a more informed evaluation of medial compartment loading, the combined use of knee adduction and flexor movements. So it's not just about lack of or varus valgus of the knee. You know, we always jump to medial compartment OA, that means you have varus deformity. But it's more than that. It's also looking at how the gait cycle, how extended the knee is. Are they able to do extension at heel strike? Are they able to do loading response knee flexion to 20 degrees? I don't know. I'm sorry, guys. I don't know what's happening here. But what I wanted to show here was it's not just the varus, but it's a varus and flexion moment together that is a problem, and that's been shown in this paper published in Osteoarthritis and Cartilage. It's not just varus moment, but it's a flexion extension moment. And the paper shows, and we have seen in clinical practice, that many people have varus, but they also have lack of extension at heel strike, or they have lack of loading response deflection, which lacks the shock absorption. And that leads to more compressive load of the medial compartment. So early osteoarthritis knee, if we carefully examine for lack of extension and the varus and treat them effectively, then you have a better chance. So we believe To reduce adduction movement, we have non-invasive strategies of gait retraining, unloaded bracing, heel wedges, hip abductor strengthening, and then high tibial osteotomy. And the conservative treatment of osteoarthritis has to be always the tensor fascia, adductor strengthening, improved proprioception balance, quadriceps-eccentric control, improved quadricep control with good pedaler tracking, lateral heel wedge if necessary, activity modification, and unloaded brace in active patient is what we currently recommend. And I think I'm going to stop here because we are exactly 1 hour. This is a lecture that we do a course for 2 days, so I can never finish everything. Let me see if there is something important that I want to show you. This is probably a best clinical example I want to show you. So this is a patient with an abnormal hip here, biomechanically unstable hip. So, and here, this is his normal leg. This is abnormal leg. So he has a significant compensated Tenderenberg gait. So every step he takes on his left affected side, he is leaning to the left every step he takes. So we told him to use a cane, but the young boy he didn't want to use a cane. So 1 year later, this is just to show you what the growth disturbance can occur just walking with this abnormal hip on one side. And this is a child, so the growth plate can compress and remodel. So in 1 year's time, if you look at him, he developed a significant varus deformity of his opposite normal leg, just walking abnormally on this bad hip, which required a hip replacement later on. But the point here is that any trunk lean or any Tenderenberg gait on the opposite side can lead to significant abnormality of knee compression on the normal side. And we see tons of people walking abnormally with their trunk, and they have compressive loads. Now, because he was a child, he remodeled his growth plate, but when you are an adult, you just compress your cartilage and have more pain. So the difference between child and adult is that in adults, you get compressive pain and articular cartilage degeneration from abnormal loading walking with this hip on this side, whereas in a child, you have growth plate remodeling and develop a deformity that requires correction. So that's an important take-home message about the effect of the trunk lean on your knee joint, and the opposite effect can also occur. If this side is affected, you can actually start getting some valgus. If you want to read about this, there's a couple of papers on relative Tenderenberg gait and abnormal knee loading in Journal of Biomechanics that you can read, but that's an example. And the last one I want to share with you is the leg length difference. What is the leg length difference? How do you measure it? The best method to measure is like this. Always check with long leg x-rays and also do available check for compensation. This is a pelvic tilt compensation for a leg length difference. Always check that. And what it really is a short leg abduction, because the short leg is here, so the pelvis is tilted, so it's abducted, and the long leg is adducted. And there are some problems with that occur. So you should always check for these compensatory mechanisms for leg length difference. I'm going to stop here, and I think let Sona ask questions about this lecture, because this voice thing is really driving me crazy now. So I'll stop here, and Sona, if you want to start the question answer session, that would be great.
Hello?
Yes.
Yes. So I guess, as usual, it was a very enlightening talk. And again, we got a lot of clinical nuggets of wisdom. And the most important part is we kind of came to know, I think this was an eye-opener, that the TFL and the IT band are very important, and they tend to increase the stresses on the medial joint. Very often, our treatment is directed towards VMO strengthening. So we do not really shift our focus to the lateral part of the knee at all. In fact, we think of them as the criminals, and we try to stretch the TFL and the IT band very often without concentrating on the entire kinetic chain of the lateral side to get them strong again. So I guess this has been a very important point or a take-home message that has been shown by Sir. I guess
I just want to clarify. I want to clarify that I always assess by OA&E for patellofemoral disease versus tibiofemoral disease. So for my medial compartment osteoarthritis treatment, which is a clinical, and I don't know if you remember, but we did that workshop last year in Pune where we showed people how to assess that. Yes, so if it's a medial problem, then my treatment strategy is different versus if I have a lateral luxation of the patella, or I have patellofemoral disease with patella tracking laterally, then of course I will do the VMO strengthening in addition to that. But what the literature has shown, and there's actually a paper.
Sir, can't hear you. So we lost you.
There's a paper by Ian Flato that actually shows this concept, and Dr. J.J. O'Connor from Oxford wrote a paper on the modeling, mathematical modeling of tightening the IT band through its insertions through the muscle and actually reducing the medial compartment load by 20%.
Yes.
So there is that evidence there. So just saying quad strengthening, you have to distinguish between a patellofemoral disease and a medial compartment disease. And I think if we do that, then we'll be able to address problems better. Unfortunately, what happens is many times they go hand in hand. Many people have both. Most people have some degree of patellofemoral crepitus problems.
Yes.
Not all of them have VMO atrophy.
Yes. In fact, even the rectus femoris tightness was again an eye-opener. I mean, again, we never assess it with the terminal stance or the pre-swing phase, and we often attribute it to other issues. So again, knowing that the rectus femoris tightness can give rise to that loss of propulsion was again a very new concept which was introduced. Yes. So no questions. It's just that we learned a lot from this lecture. And yes, so I guess in case Dr. Sham needs any queries or has any queries from the audience, I think they can ask them.
Okay.
Okay, sir. Okay, sir.
So I just want to make an announcement for people who are attending this that there will be a follow-up topic. There will be 2 more lectures on biomechanics series soon. I think the second one is going to happen 2 weeks from now. And that's on a very interesting topic called weight bearing. When we order non-weight bearing, is it really non-weight bearing? When we order 50% weight bearing, how do we achieve 50% weight bearing? This has been a chronic problem in the way we teach our patients, and what should we do simply to change that concept. When patient is taking bed rest, is the joint actually getting bed rest? And how do we make it happen? So that will be 2 weeks from today. And then we will end with what my favorite topic is, lever arm dysfunction, which is basically incorporating what we did today in frontal and sagittal plane with rotational abnormalities or rotational plane abnormalities and putting it together and that will happen in 2 weeks from now. So there will be 2 more biomechanics series that we will do. I think next to next Friday is the weight bearing, and then in a month we will do the lever arm dysfunction. So thank you all for your attention, and thank you again Ashok, Sona and Parag for introducing me and allowing me to do this. Thank you very much. Okay, bye-bye.